Hello, my name is Niti. Today I'm presenting this presentation on my cardiovascular patient oral presentation. I'm doing this on my patient that came into the clinic this week. He came in, he's a 56-year-old African American male who presented to the clinic with as a new patient with a chief complaint of intermittent episodes of rapid and irregular heartbeat. He reports that his this episode has began approximately 3 weeks ago and has occurred several times per week. He describes the sensation of his heart, say that it's been racing and skipping beats. Episodes generally last between 5 to 15 minutes, although both occasion it's happening occasionally. It's only when he's climbing stairs or he's working like in his yard or in his garage. He reports associated shortness of breath, lightheadedness, but denies any syncopal or chest pain episodes, orthopnea, or leg swollen. History of present illness. Patient states that these episodes has become slightly more frequent over the past week. He drinks 2 to 3 cups of coffee daily, and occasionally uses as energy drink as an energy drinks for while he's working in his garage. He denies any illnesses or any fever, recreational drug use, or excessive alcohol use, or he has not previously has been evaluated for this symptoms or has not had any EKGs done and prior to this visit. Pertinent medical history. His medical history includes a hypertension diagnosed approximately like 8 years ago, and also with the hyperlipidemia. He reports that he has not had been consistent with his medication and has not had any routine primary care visit or follow up for approximately like 2 years. His current medication he's taken are amlodipine 5 mg daily, atorvastatin 20 mg nightly. Although he admits missing several dosages each week, his sorry his father had hypertension, and he died from a stroke at age of 60s. His mother has a type 2 diabetes, mellitus, and also hypertension, history of hypertension. There's no known family history of sudden cardiac death or inherited arrhythmias. Social history is significant for formal tobacco use for approximately 10 packs a year. He quit like 4 years ago, drinks alcohol occasionally, lifestyle relatively sedentary, and his diet includes frequent processed foods and high sodium intake. Review of system. Pertinent cardiovascular review is positive for intermittent palpitations and occasional exertion, dyspnea, lightheadedness. He denies chest pain, syncope, orthopnea, proximal nocturnal dyspnea, and also peripheral edema. His blood pressure is within a normal limit, 140, a little bit elevated, I could say, 148/88. Heart rate 92, respiration 16 per minute, oxygen saturation 98% on a room air. His BMI is 28.7 kgs. Cardiovascular examination reveals irregular rhythm at this time of examination without murmur, rubs, or gallops. Peripheral pulses are 2 plus and symmetric. Lungs are clear bilaterally, and there is no peripheral edema. Neurological exam is normal without focal deficits. Assessment and differential diagnosis. My primary concern is the proximal cardiac arrhythmia, particularly proximal atrial fibrillation or another supraventricular tachyarrhythmias. The intermittent nature of these symptoms makes an arrhythmias possible, even though his rhythm is regular. During today's examination, my differential diagnoses include proximal arterial fibrillation or other supraventricular tachycardia, premature arterial or ventricle contractions, hyperthyroidism, or other metabolic electrolyte abnormalities, medication or stimulant related palpitations, anxiety related palpitations, less likely underlying structure heart disease or ischemic heart disease, because AFib can be intermittent and normal rhythm during the office visit would not exclude an arrhythmias. Current guidelines support clinician confirmed ECG evidence with established or arterial fibrillation diagnosis and recognize ambulatory ECG monitoring as an important diagnostic option for intermittent symptoms. Plan the first step to be 12 lead EKGs done, and the clinic laboratory evaluation will include CBC, comprehensive CMP, magnesium level, TSH, fasting lipid panel, hemoglobin A1C, identifying reversible or contributing conditions. Because his symptoms are intermittent, I would order ambulatory ECG monitoring, such as a patch monitor, or to correlate his symptom with his cardiac rhythm. If symptom occurs in frequently longer duration, even a monitor would be considered, and echocardiogram will also be considered to evaluate cardiac structure and the function. If the ECG or clinical findings suggest a structural heart disease, I will review his blood pressure, medication and adherence, and reinforce consistent use of antihypertensives and statin medications. The recently updated hypertension guideline emphasizes acute BP assessment, cardiovascular risk reduction, lifestyle modification, and appropriate pharmacological treatments when indicated. I will also, if AFib is confirmed, I would calculate his stroke risk using appropriate validated risk assessment and discuss the anticoagulation and the rate rhythm control option based on the confirmed diagnosis of overall risk profile. In the summary, I have a 56-year-old African American male presenting as a new patient with the recurrent palpitation, intermittent lightheadedness, and also a mild exertion dyspnea. Although examination is currently reassuring, the episode nature of his symptom raises concern for the proximal arrhythmias. My priority is to document the rhythm with the ECG and ambulatory monitoring while evaluating for the reversible cause and underlying cardiovascular disease. Early identification of an arrhythmia will allow appropriate treatment and reduce the risk of complications. Thank you so much for the listening, the presentation.